For a long time, the first question in almost every breast augmentation consultation was some version of, how big can I go? That's not the question I'm hearing most in 2026. The question I'm hearing now is something closer to, how do I get a result that actually looks like it belongs to my body? That's a real shift, and it's not just a trend on social media. It reflects a genuine change in how patients are thinking about augmentation. Less about maximizing size and more about proportion, movement, and a result that holds up to close inspection. There's even a name for the aesthetic a lot of patients are asking for now: ballerina breast augmentation. Smaller, softer, more proportionate, designed to look like it was always there. Today, I want to talk you through what's actually driving this shift, what's changed about implant technology, including a newer option called Motiva that I want to spend real time on, and what's changed about surgical technique, including a technique called ProgressiveGel that I think is genuinely one of the more underrated advances in this field, and one that applies to a much wider range of patients than most people realize. I'm Chris Lee, MD. This is Honestly. Let's get into it. Let me give you the picture of what's actually shifting. For years, the trend in breast augmentation toward larger, more dramatic results, bigger implants, fuller projection, a very recognizable augmented look. What's happening now is almost the inverse. Patients are increasingly choosing smaller, more proportionate implants. The average request size has moved down meaningfully, and a lot of patients are specifically asking for results that fit their frame rather than override it. This is the ballerina breast augmentation, sometimes called yoga boobs. It's not a surgical technique, it's an aesthetic goal. Graceful, proportionate, natural movement, a soft upper slope rather than an aggressive projection. Typical implant volume in this category runs smaller than what was standard even 5 years ago, often anywhere from 150 to 325 range, depending on the patient's frame, versus implants that used to commonly run 350 to 400 cc's. There are a few things driving this. Part of it is an aesthetic pendulum. Trends in beauty are cyclical, and we're in a moment that favors elegance and proportion over maximalization. Part of it is functional. Active patients want a result that doesn't interfere with their own body, with how their own body moves. And there's a newer driver that's become even more significant: GLP-1 weight loss medications. Patients who've lost meaningful weight on semaglutide, tirzepatide often experience volume loss in the breast along with the rest of their body. What they're asking for is less dramatic enhancements. It's more about restoration of what they did have. That's a fundamentally different conversation than augmentation aimed at significant size increase. And it's one of the reasons anatomy-first planning has become the dominant philosophy in 2026. So what does anatomy-first actually mean? I want to spend a minute on this phrase because I think it's the most useful concept in this entire conversation. For a long time, breast augmentation was approached somewhat like ordering off a menu. Patients would come in with a cup size in mind. The problem is that cup size isn't actually a reliable measure of anything physical. It varies by band size, by bra brand, by the shape of the breast itself. Planning a surgical result around a letter is planning around a moving target. It does give a sense of where you're starting and where you'd like to end up, but in general, cup size is never guaranteed. Anatomy first planning starts somewhere completely different. It starts with your own chest width, your existing breast tissue, and your skin elasticity, your frame, and your goals for how you want to look in clothing versus without it. From there, we figure out what implant volume and profile actually fits your anatomy, rather than starting with a number and hoping that it works on your body. This is why two patients who ask for natural looking results might end up with a completely different implant volume. A 280 cc implant on a narrow chest with moderate tissue can look proportionate and full. The same 280 cc implant on a much wider chest with very little natural tissue might look underwhelming. The number means very little without the anatomy behind it. Next, let's talk about technology, because this has evolved in the last few years, and I think it's underappreciated by patients researching it. There's a newer implant called Motiva that received full FDA approval in the United States in 2024 and has become an increasingly significant part of this conversation and a part of my practice. I want to walk you through what makes it different, because the differences are substantive and not just marketing, which I did think they were initially. The shell technology is something called SmoothSilk. It's a nano-textured surface designed to be highly biocompatible, meaning it interacts more gently with the surrounding tissues when it's implanted in the body over the implant surfaces. The clinical reasoning is that a smoother, more biocompatible surface produces less chronic inflammation and less scar tissue formation around the implant. And the data is actually compelling. Motiva has reported a near zero rate of capsular contracture, which is the hardening and tightening of scar tissue around the implant. That's historically been one of the more common complications requiring revision surgery. The gel inside is called the ProgressiveGel. It's designed to adapt its shape somewhat based on the body position, which contributes to a more natural feel and movement, whether you're standing, sitting, or lying down. I'll be straight with you about something though. Motiva isn't automatically the right choice for every patient, and no implant brand is immune to every possible complication. Patients with very little natural breast tissue can still experience visible implant edges or rippling, regardless of which implant is used. That's more a function of your own tissue coverage and placement technique than the implant itself. Which brings me to the part of the conversation I think is even more interesting than the implant itself, where we put it. So, placement. This is where I want to be really precise because there's a lot of confusion online about different techniques, and the distinctions actually matter a lot for who's a candidate for what. Let's start with the traditional approach, submuscular or dual plane placement. Here, the upper portion of the implant sits beneath the pectoral muscle, and the lower portion sits beneath the breast tissue. To create the pocket, the surgeon has to release portions of the muscle and, in the lower pole, cut through the breast's internal Cooper's ligament, the fibrous bands that act like internal support structures to the breast, almost like an internal bra. This has been a reliable, well-studied technique for decades and remains an excellent option for many patients, particularly those with thinner tissue who need more coverage. But cutting those ligaments means you lose some of that internal support, and you can get changes in sensation and a longer recovery because of the muscle work involved. In addition, because the implant is under the muscle, it is subject to muscle contractions, which means the implant can move and deform with every muscle contraction, something called animation deformity. And over time, implants can migrate down and out to the side. So, has its pluses and minuses. Now, subfascial placement. This is sometimes lumped in with preservation techniques, and I want to clarify why that's not quite accurate. In subfascial placement, the implant pocket sits above that muscle beneath the fascia. The muscle itself isn't cut, which is an improvement over dual plane in some respects. But to create the pocket, the surgeon still has to dissect outside the breast's natural capsule space, which means disrupting more of the breast's own boundary structures, including those of the Cooper's ligaments and the circummammary ligaments that defines the breast's natural border. You're avoiding the muscle, but you're still creating a new space that lies behind the breast tissue and disrupts what the breast was actually doing on its own and is still sort of a separate entity from the breast. Here's where something called preservé is genuinely different. And this is the part I think most patients and honestly most content online get wrong. The preservé technique creates the implant pocket within the existing capsule space of the breast itself, between the breast gland's own capsule and the body of the gland and fat behind it. That space already exists naturally. We're not creating a new pocket outside of the breast's own architecture. We're working within it. Because of that, the circummammary ligament, the ligament that defines the breast border, is never cut. None of the internal Cooper's ligaments are cut either. The implant essentially nests or nestles within the breast's own existing supportive structure, the way a hand fits into a glove that was already there, rather than us building a new pocket somewhere else and hoping the breast settles around it on its own. This has a few real consequences because that internal ligamentous support stays completely intact. There's some genuinely compelling data suggesting implant malposition, meaning the implant shifting downward or to the side over time, which has historically been a common problem in other techniques. It becomes far less common in this technique. The internal bra effect of the Cooper's ligament is doing exactly what it was always doing, just now with an implant nestled inside that same structure. And here's the part that surprises most patients. Because we're working within the breast's existing space rather than creating coverage from a muscle or fascia, preservé can be performed on nearly every patient, including patients with very thin natural tissue, who are often told they're not candidates for muscle-sparing techniques, like subfascial placement, because they don't have enough coverage. With preservé, the support isn't coming from tissue coverage over the implant. It's coming from the breast's own ligamentous structure, which is present regardless of how much fatty tissue a patient has. That's a meaningful difference in candidacy compared to subfascial placement, which really does depend on having moderate to full natural tissue to avoid visible rippling or edge show. Recovery also tends to be a lot faster and more comfortable as well. Since there's no muscle disruption at all, some patients describe a noticeably easier first few days compared to a dual plane. Patients can go back to full activity at 2 weeks and with much smaller incisions. Many of these procedures can even be done under local anesthesia with light sedation, so you're awake the entire time rather than general anesthesia, which is on its own a meaningful difference for some patients who don't want to be completely asleep. We essentially take breast augmentation from a full surgery to a small procedure, like colonoscopy or a really big haircut. All right. So honestly, scale time. Let's talk about patient satisfaction. I would say it's very high. And this is actually improved as the anatomy first philosophy has become more standard. When implant size is chosen based on frame rather than a target cup size, satisfaction tends to be much more durable over time. What about longevity? Implants are considered lifetime devices regardless of the brand, but modern options, including Motiva, are built for meaningfully long-term durability, often backed by warranties for rupture and capsular contracture. The Preservate technique specifically has shown promising data on long-term implant stability and reduced malposition because of the uses the breast's own support structure, and that all stays intact. Recovery burden. For the Preservate technique, recovery tends to be genuinely faster and more comfortable than traditional submuscular placement. No muscle disruption means many patients describe a notably easier first week and back to full activity, including the gym, within 2 weeks. Now let's talk about the fear versus reality gap. This one's interesting in 2026 because the fear has actually flipped from what it used to be. It used to be fear of complications or unnatural firmness. Now I hear more fear of looking overdone. The honest answer is that with current technology and techniques, a well-planned augmentation built around your specific anatomy very often looks like it was always there. Now, let's be specific about candidacy, because this is where the corrected understanding of Preservé actually matters most. This is genuinely broad, because the technique works within the breast's own existing structure rather than depending on tissue coverage. It's appropriate for most patients, including thin patients who historically have been steered towards dual plane because subfascial or other muscle sparing approaches wouldn't have provided enough coverage for them in the implant. Patients prioritizing a soft, natural feel and fast recovery. This surgery is great for. Patients wanting to preserve sensation and avoid disrupting the muscle. Great. Patients with intact, healthy Cooper's ligaments to begin with, which is most patients who haven't had any significant prior breast surgery or trauma. Patients for whom dual plane or subfascial approach may still make more sense. Those who have had significant prior breast surgery affecting the existing capsule space or ligamented structure. Patients seeking very large, dramatic augmentation, where implant volume exceeds what the existing breast envelope can comfortably accommodate. Those who want those with significant ptosis or asymmetry who may need a lift combined with augmentation is a different conversation altogether, although smaller lifts can be done in conjunction with Preservé technique. The honest summary, let's talk about that. Preservé has meaningfully broader candidacy than people assume, including for thin patients, as we've talked about, specifically because of how it works within the body's own structure, rather than depending on added tissue coverage. That's exactly why this is worth bringing up directly in a consultation rather than assuming you're not a candidate. If this conversation has you considering a consultation, here's what a good one should go over. Your surgeon should be assessing your chest width, your existing tissue quality and quantity, your skin elasticity, and your goals, not just asking what cup size you want. Ask what implant options they offer and why they'd recommend one over another for your specific anatomy. If you're interested in Motiva specifically, ask whether your surgeon offers it. Ask what placement techniques they're recommending, and specifically ask whether Preservé is an option for your anatomy. Many patients never hear about it because not every surgeon offers it, and you may be a better candidate than you'd assume. And only surgeons that have been trained in Preservé technique can offer it. And only board-certified surgeons can offer Motivas. Ask to see before and after photos of patients with similar starting anatomy to yours. A good surgeon will be honest about trade-offs and explain clearly why they're recommending one technique over another for your specific case, not just defaulting to whatever they do most often. A surgeon who explains the actual anatomical difference between techniques rather than using marketing language is always a green flag. Red flags are anyone who tells a thin patient they're automatically not a candidate for muscle sparing or ligamentous sparing approach without explaining the specific technique being discussed. Now, here's what I want to leave you with today. The conversation around breast augmentation has genuinely changed. It's not about how big you can go anymore. For patients, it's about how natural a result can fit your specific body. The technology has caught up to that goal, and so has the technique, including options like Preservé that work for much wider range of patients than most people realize. If you've been considering this and you're worried about looking overdone, you've been told that you're not a candidate for a gentler approach because of thin tissue, that's worth revisiting in a real consultation. The right answer depends on your specific anatomy, of course, and not a general rule. If you found this useful, follow Honestly Pod on YouTube and Honestly on Apple Podcasts and Spotify. Leave a comment with your questions, share it with someone who's been thinking about this. And if you want to talk specifics about your anatomy and goals, reach out to my team at Clarioplastic Surgery. The link is in the show notes. I'm Chris Lee, MD. This is Honestly. See you out there.